oncologist at Dana-Farber Cancer Institute, where he heads the ECD Care Center. He's studied histiocytic malignancies for over 20 years. He's going to give us an overview of Erdheim-Chester disease.
Thank you, Jean. Paul, my teenage daughter, described my PowerPoint skills as amateurish. So you have my, she describes a lot of things I do as amateurish, but so thank you everyone for having me speak today. I think I have 20 minutes to summarize what we've learned in 100 years. So we should have about 18 minutes to spare. But I really, today I look at my role as sort of like a leadoff hitter in baseball. A leadoff hitter who can't run and can't hit a fastball, but leadoff hitter nonetheless. And that really just to set the stage for the speakers that will come after me. And hopefully in a disease, in terminology and in a sense that is understandable. So these first two statements are sort of the dogma of histiocytic neoplasms, the expression of our faith, if you will. So these are diseases of monocyte-macrophage derivation that have identifiable recurrent mutations. Fantastic. What does that mean? Well, we'll delve a little bit into that in the next few slides, but you're going to hear, I think, a lot more about that in some of the subsequent talks. I'd say there's two common questions I get when I first meet with someone who has ECD. One is, is the prognosis really as bad as Google says? That answer is demonstrably no. The prognosis is much better than some of the scary things that somehow still seem to come up as the first thing or two that comes in a Google search. The second is, they say, I saw one doctor who said this is an inflammatory condition. I saw one doctor who said this is a cancer. What is it? And I say, yes, which seems sort of counterintuitive. When my daughter was in elementary school, she said, Dad, there's a kid in my class who roots for the Red Sox and the Yankees. And I'm like, that's biologically impossible. I believe you saw a unicorn in the backyard. I do not believe there's a person who roots for the Red Sox and the Yankees, but it is possible actually for something to be inflammatory and neoplastic. And it's not unique to ECD, honestly. Some of what I do is lymphoma. And we see some of this in lymphoma and other malignancies as well. But we'll talk about the underpinnings of some of that. If there's any immunologists in the audience, I apologize. I've crushed a small part of your soul with how much I've simplified this. But this is sort of a basic background of monocyte-macrophage development. And at their core, I describe these cells as sort of the first responders of the immune system. So they recognize and engage something that shouldn't be in the body. It could be a foreign body, a splinter, could be a bacteria, but they're sort of the guardians of the immune system. And like all blood cells, I don't know if we have a pointer. Oh, we do. So they start as hematopoietic stem cells. So hematopoiesis is just a fancy Greek term for making blood. So these are stem cells that they're not the embryonic stem cells you often hear about in the news. These are committed to a blood lineage. And they can take a variety of career paths. So they can become myeloid cells or lymphoid cells. And then within that career, there's a bunch of subspecialties. And eventually they can further differentiate into monocytes. So we're sort of getting into that monocyte-macrophage derivation. And then further still into these sort of tissue resident cells. So cells that go out into various tissues and help perform immune function. So those are dendritic cells and macrophages, and actually microglial cells that support some of the functions of the nervous system. So maybe this explains some of the nervous system findings we see in ECD. And then the lymphoid cells, actually some of them can develop into these plasmacytoid dendritic cells, which can give rise to a separate neoplasm, but all of them are rare. Diseases of these tissue resident macrophages and dendritic cells are very rare. When I think about how we diagnose someone with a disease, so last night, even at the scientific discussion, it came up, how do we say someone has Erdheim-Chester disease? What does it mean? Is it one disease? Is it multiple diseases? And I have an uncle who's a retired detective, and I think establishing these diagnoses is very much like solving a crime. So you have a description of what happened. Did the symptoms come on in a week, i.e. is this a rapidly developing process? Or does the patient look back and say, okay, for 3 years, I've had these knee pains and I've felt terrible. It's been a much slower onset. And typically with ECD, the symptoms come on relatively slowly. And therefore, it can be overlooked by patients and physicians for a very long time. The typographical error here, the disease is more common in men, but not quite a 3-to-1 ratio. So I'll have to fix that. But it's typically a disease of middle age. So, if you see a child with similar symptoms, it's not impossible to have Erdheim-Chester disease in childhood, but this is usually a disease of people roughly my age. So that's sort of, what happened, a description of the crime, so to speak. And then you have a picture of your suspect, which we see on the right-hand side, marked in A. And Erdheim-Chester disease is characterized by what's called these Teuton giant cells or foamy histiocytes. So you can see a lot of clear areas within the pink of this biopsy. This looks like a skin biopsy, actually. And so those are those foamy histiocytes. Ordinarily, you shouldn't see those there. So that's Erdheim-Chester disease isn't the only thing that can do that, but it starts to get you in the neighborhood of what may be going wrong. And then you have the fingerprint, so to speak, which is what we call immunohistochemistry, or the protein signature of these cells. So various immune cells and other cells in the body are characterized by the presence or absence of certain proteins on their surface. And that's what helps us, amongst other things, helps us tell, is this Erdheim-Chester disease, is this lymphoma, are we seeing something else? So not to get too deep in the weeds, but CD68 and CD163 are proteins that are shared in cells of monocyte-macrophage derivation. So, now we have a description that fits with the disease. We have a picture that fits this with the disease. And now we're starting to get a protein fingerprint that fits with the disease. And ultimately, as is true now in most of oncology, it's really the genetic evidence. So, the clincher at the end of Law and Order SVU, where they pull out the DNA evidence and, they get the guy at the end. So demonstrating these genetic mutations, very important, not only for establishing the diagnosis, but also, as we'll see, particularly in future lectures, very important in determining treatment. So this is the sort of the clinical spectrum of ECD. These are 3 very well characterized data sets. There are others. Really a universal, almost universal finding is the involvement of bone. And I'm going to show some pictures in a few slides of what that looks like. But you can have ECD without having bone involvement, but it's unusual. And if we see that, or if we're entertaining the diagnosis and there's no bone involvement, it certainly makes us look for other possibilities. Involvement of the kidney, or really the tissue around the kidney, is quite common. And then coating of the aorta, which is the major blood vessel that brings, major artery that brings blood from the left side of the heart to the rest of the body, is quite common. But what you'll really notice from this list is it's a long list. And I think many of you probably have lived this or seen this, in that it is a disease that really can affect just about any organ system, which is why for a long time it really didn't have a specialty, so to speak. It wasn't like a cardiology problem or an endocrinology problem. For a long time, these histiocytoses were sort of diseases without a home. But now with the demonstration of these recurrent mutations, they've sort of found a home, so to speak, within oncology, because we use a lot of therapeutics that target those mutations. So these are pictures provided to me by the internet, mostly. They're publicly available, searchable. So as I mentioned, the typical finding in ECD in about 95% of patients is bone involvement, classically involvement of what we call the long bones of the legs. So the old song, the leg bone connects to the hip bone, or whatever it is. So the femur, particularly the part of the femur above the knee, is commonly involved. And then the tibia, which is one of 2 lower leg bones, is also commonly involved, often in areas around the knee. And there are certain areas of bone that tend to be affected and certain that tend to be spared for reasons that are unclear, at least to me. So many times radiologists will actually raise ECD as a diagnostic possibility. I would say for a lot of patients that I've seen, it's actually a radiologist that has first thrown ECD into the list of possible diagnoses. The other classic appearance is what we call hairy kidney. So here's the kidney right here. You can see this rim of gray around the kidney. I hope, if you can see my arrow. That really shouldn't be there. So there's lots of things that can do that. But you can see where the red arrow on the bottom is pointing. You see almost like these finger-like projections, or what are called villus projections. So again, that's not unique to ECD, but it certainly raises the possibility of ECD. And then in the vertical pointing arrow, you can see that's the aorta. Again, there's that rim of gray around that more central area of lighter gray or white, and that really shouldn't be there. So that's another indication that maybe we're dealing with ECD. Although there are other processes that can do this. So just seeing the radiology findings alone is really not enough to make the diagnosis. And one thing you can appreciate, if we're looking at bone and these areas essentially in the back of the abdomen that are commonly affected, these can be difficult areas to biopsy. So a lot of times we do biopsies by having a radiologist use a CT scan to guide a needle into the tissue we're interested in. And, I don't know, I think there are radiologists in the room. We like to give radiologists a hard time, honestly, other medical specialties. And it's kind of unfair, but it happens. But you can see that it'd be difficult to kind of get a needle into that little area or that little area, or any of us can envision putting a needle into a bone is not an easy thing to do. It's difficult to get an adequate sample. This issue is not unique to ECD. That's why there's a lot of interest in what we call liquid biopsies, where we can do blood tests to look for proteins or genetic changes characteristic of a disease to make a diagnosis without having to do the traditional biopsy. But sometimes it can really take a while to get enough of a sample to get that picture of the suspect I was talking about. So the ocular findings in ECD also quite common. So xanthelasmas are fleshy, yellowish colored tissue near the eye. Again, not unique to ECD. You can see this in certain syndromes of very high cholesterol and other conditions. But a common, though subtle finding. Most physicians might notice it, but not really appreciate the implications. And then exophthalmos, another fancy Greek word, but basically just means bulging of the eye. So sometimes the ECD can infiltrate the tissue behind the eye, just mechanically push the eye forward, and you get some bulging of the eye. And I've had patients who say, gee, I was looking at, back at pictures of me from 10 years ago, and now today my eyes look a little bit different. It happens so slowly and so gradually that patients and their families often don't notice it. But when you look back in retrospect, you can see it. Again, there are other things. So there's a lot of commercials lately for some reason about thyroid eye disease and some treatment for thyroid eye disease. So thyroid abnormalities can cause this exophthalmos. It's not unique to ECD, but it is a pretty common finding. And then heart involvement is really unique, I think, in that, when we think of heart disease, my uncle had a bad mitral valve. They replaced it, worked fine. We all probably know or have experienced the blockages in coronary arteries. They put in a stent, you open up the artery, good to go. But ECD can really affect any of the cardiac structures. So it can affect the cardiac musculature itself. So sort of this hazy black area here. This is, you'd have no way of knowing this, nor would I if I hadn't read this paper, but this is the right coronary artery. So it can encase the coronary artery, so it can cause problems with blood flow, and in addition to problems with the heart muscle. Or the pericardium, which is the lining of the heart. So you kind of see these outpouchings of tissue and then actually causing fluid or irritation around the heart. And then it can also affect the heart valves. So ECD patients really require comprehensive cardiac monitoring and evaluation, and preferably a cardiologist with experience with the disease, which admittedly is not easy to find in many places. And then finally, nervous system involvement is also relatively common. Classically, it's the posterior fossa, which is basically the back of your brain, and the brain stem, the first part that goes from the brain down into the spinal cord. But it really can affect any area of the brain potentially. And this, in my experience, results in a good chunk of what we call the morbidity, or essentially the symptoms or side effects of ECD. And that, neurologic function obviously touches on everything. And neurologic injury or inflammation is somewhat unique in that, very often when you address the underlying cause, if you treat the ECD, sometimes, that insult has been done and the symptoms don't reverse. So I think Gaurav or somebody was talking about this last night. Gee, your scan looks great. Okay, well, I feel lousy. Now you may feel lousy because of the treatment, but you may feel lousy because these systems have been disrupted. And unfortunately, they're still compromised by scar tissue or inflammation or other factors. So, and there are other, pictures that I could show, but this gives you an idea of the spectrum of the disease. And again, why it is such a challenge sometimes for physicians and why you really need a multidisciplinary team to manage patients. I was embarrassed by the immunology slide, but if I tried to talk about neurology in front of Eli, I'd be even more embarrassed. It's the nervous system in particular is always a black box. So I mentioned that these are diseases of myeloid derivation. And so, the natural question becomes are there other problems in the myeloid system that occur in ECD patients? And there's this condition called clonal hematopoiesis, which starts usually right around when you hit my age, 50 plus or minus, where certain cells in your blood system get mutations that give them a little bit of an advantage in growth and survival. So when I look out in the room, I see 100-ish people. You're all people, but you look a little bit different. I don't see any identical twins. Clonal hematopoiesis would be if I looked out in the room and I saw 90 people who looked different and I saw 10 Kathy Brewers. The world would be a better place with 10 Kathy Brewers. That doesn't always translate into your immune system, in that sometimes these clones or these cells that are just copying one another can evolve into other blood cancers. So, how that ties into the genesis of the ECD is there some inciting trigger that causes both processes, this clonal hematopoiesis and the ECD, or does one start and trigger the other? When a cell has one mutation, it makes the cell unstable and susceptible to other mutations. So I think these are some of the things that we need to work out. I don't think I have to lavish Gaurav with more praise, but he wrote a nice commentary on this very elegant paper if you want to read it in the journal Blood. So I mentioned, when patients ask, is this a cancerous process or an inflammatory process? I say yes. And they immediately question me. But we do see a lot of inflammatory phenomenon in patients with ECD and in fact, autoimmune illness. So, in this series, 4% of patients developed autoimmune thyroid inflammation, which is higher than you would expect in the background population. And similarly, just under 2% had lupus or Sjogren's syndrome, again, much higher than the incidence of those diseases in the background population. And antibody tests are notoriously difficult to interpret in autoimmune disease, but all the autoimmune biology tests that I list down here can be markers of autoimmune illness, or certainly markers of an inflammatory environment. So there's no doubt that these patients have an inflammatory background that may account for a lot of the symptoms above and beyond, what organs are actually being affected by the disease. And we see this, so I mentioned clonal hematopoiesis, that's associated with a mutation often in a gene called TET2. There's a lymphoma called AITL that has TET2 mutations where we see a lot of inflammation. We know that TET2 mutations actually increase the risk of coronary artery disease because of inflammation. So there's some biological underpinning, I think, for why we see both the mutational profile and then that translates into the clinical profile. My time, I think, is up, and I'm going to keep going until someone drags me off. I only have a few more slides. So I put this slide up for my brother, Mike. Hopefully somehow you're seeing this. Every family gathering, every summer when we're fishing on the boat, my brother says, how long did you spend in school? How long did you spend in training? You're supposed to be a Harvard guy. Why haven't you cured cancer? Kind of an unfair question. I would say one, we do cure cancer quite a bit, thankfully. But two, it's not as easy as it seems. It seems logical. Here's a mutation, block that mutation, easy peasy, we're done. I can go play golf or spend the rest of my days on the boat. But there's a lot of redundancy built into these systems, and it's kind of like an airplane. There's certain pathways that aren't that important. If the coffee machine breaks on your flight home, it's like I'm a little disappointed, but it's okay. There's no backup system in the coffee machine. If the engine goes down, you've got my attention. So a lot of these critical pathways that we need to target in oncology have workarounds or they have redundancies. So it's not always as simple as just blocking an abnormal protein or blocking an abnormal gene. And when mutations happen, a variety of things can happen. So one is a gene can be silenced or a protein can lose its function. It's very hard to correct something where function has been lost. That's a big focus of genetic therapies and sort of replacing damaged genes, but it's much easier to target mutations that cause something to become overactive, because then you can kind of tamp them down rather than replacing lost function. And then sometimes mutations just amplify a signal from somewhere else. So you can actually, block a protein that's amplifying a signal by blocking things, that feed into that signal. So it's the target you think is important isn't always necessarily the target you have to go after. I guess that's how I would say it. But I'm going to break this slide out in a couple of weeks when I go fishing with my brother. So again, this is a bit of an oversimplification, and you're going to hear more about this, I'm sure, in the talk on treatment. But this is, a roughly linear concept of the RAS-RAF-MEK pathway that's important in so many histiocyte disorders, including Erdheim-Chester disease. And I just show there some of the drugs that are either FDA approved or in development that can target along this pathway. So there's lots of opportunities here, and there's lots of opportunities to target other things that sort of feed into this pathway or support this pathway. Yes. Gene is going to pull me off the stage. So as Paul mentioned earlier, we developed NCCN guidelines to treat this, to treat ECD, and really, I'm not going to walk through all this, but the reality is almost everything you see here is designed to block one of these mutations. The era of chemotherapy, though not over, is very much in its decline, and that's a good thing. We're much more rational about how we treat things. Unfortunately, in many cases, at least at the moment, it seems like treatment needs to be indefinite. And Paul touched on this a bit, but a short list anyway of key questions. What causes the disease? We don't know why these mutations occur. Does everyone need treatment? If you have, ECD in your knee bones that isn't causing you a lot of symptoms, do we need to intervene upon that? There are some slow-growing lymphomas or prostate cancer that we don't necessarily treat right away. What's the optimal treatment? A BRAF inhibitor, a MEK inhibitor, both, neither. These are some of the things we need to answer. And I think it would be beneficial, hopefully someday, if we can get patients to the point where we don't need to do indefinite therapy and really extrapolate from lymphomas, leukemias, other diseases, where we use highly sensitive techniques to find infinitesimal levels of markers of a disease under study in the bloodstream that tell us, okay, it's safe to stop medications now, or no, we're still seeing evidence that this disease is active. We need to continue treatment. So big thing I would be interested in is, can we spare patients indefinite treatment? And then Gaurav is going to talk extensively, I think, about survivorship issues this afternoon. But you can see, just given the number of organ systems that are affected, really requires diligence on the part of the medical team and good rapport with the patient to elicit some of these symptoms or complications. So I apologize for going over, but 100 years and 24 minutes, 50 seconds, I think still not bad. So.
Appreciate that.
Yeah.
All right. Thank you. Just for a minute. In the interest of time, it might take one, if somebody has one burning question for Dr. Jacobsen, otherwise you could catch him on the break.
Yes, I'm in a coffee addict, so you will find me very abundant coffee machine.
Great.
Okay, thank
you so much. And thank you for that overview. I'm gaining some understanding myself.